And welcome back to another episode of Hybrid Healing Hour. Today, we are going to be discussing obstructive sleep apnea, and we have a very special guest with us, Dr. Kenneth Mogell. I'd like you to go ahead and tell our audience about how you got to where you are today and a little bit about your background.
I've been practicing dentistry now. This in June will be 40 years.
Wow.
Yeah, it's amazing how time flies. About 15 years ago, I don't even remember how I got involved with treating patients for sleep apnea, but ended up taking a course, and it really excited me and interests me, and we've just taken off since then. I haven't done any dentistry in 5 years. I'll never do dentistry again, yay me. And we've been doing it for 15 years. My background is, my undergraduate degree is in nursing. I practiced nursing 3 years before I went back to dental school. And went to dental school, undergraduate's Florida State, so I am a Seminole. Dental school is Florida. And we've been living down in this area since we graduated in 1984. And we've been in our office now, our practice for 38 years.
Wow. So I think you have some experience doing this.
Yeah, we have a little bit. We as we were talking before, we're quite busy. We probably see, I think last year we did close to 800 appliances. So we're quite busy.
Wonderful.
It's a good thing.
Yes. Well, I think that goes to show that, obstructive sleep apnea is so prominent, and we're going to get right into that.
Yeah. So most people wouldn't think of a dentist for sleep apnea.
No, they don't.
But a lot of people don't realize that sleep apnea is not a problem with the lungs, which is usually pulmonologists are the ones who treat it, but it's more a problem with the oropharynx.
That's right.
And with the back of the tongue, and who's in your mouth more than the dentist?
And you hit the nail on the head. The most common thing that blocks off your airway is your tongue. And so the whole point of what we do with our oral appliances is we move the lower jaw slightly forward, hoping to stimulate the nerves of the tongue to bring the tongue to the front of the mouth. As I tell my patients, it can't be in two places. If it's at the front of your mouth, it can't be in the back of your throat. That's an oversimplified view of what happens, but that's basically how an oral appliance does work.
Yeah, it's amazing as to what our patients think causes snoring and causes sleep apnea. A lot of people think it's the nose. So that's why those breathe right strips became so popular, right?
And they don't do anything. But there are actually better nasal dilators out there. So we always evaluate the nasal valve in every one of our patients, because those of us, including myself, who have sleep apnea, now I have moderate sleep apnea, I don't snore a drop. So you don't have to snore to have sleep apnea. At the same time, my wife is what we call a primary snorer. She doesn't have apnea, but she snores like a damn bear.
Yeah.
And she wears an oral appliance, takes about 80% of the snoring out of the picture, other 20% not quite as loud. There's always caveats and exceptions. You have a couple glasses of wine late in the night,
right,
rolls onto her back. The supine position is always the most difficult. She's going to snore. But typically, 80% of the people, you do get that much of an improvement of their snoring there. Yeah.
That's amazing. Yeah. So let's talk a little bit about sleep apnea. Sleep apnea is seen in all age groups, but the frequency increases with age and increases with obesity. And as we're seeing, our population is definitely getting bigger. So I'm sure that the numbers of sleep apnea that you're seeing are increasing as well.
Yeah, we are. But you'd be surprised. I'd say still half of our patients are not morbidly obese.
Right.
Do you consider me? My BMI says I'm obese, but I'm not obese.
Oh.
Right.
So you don't have to be obese to have sleep apnea, but 50% of the people are obese.
Yeah.
Yeah. You get those extra fat pads in the neck, and then they lie onto their back and they collapse.
But I think that also has to go with, like you said already, the anatomy of their mouth. There's something called the Mellompathy score, right? And can you describe that to our audience?
Yeah, Mellompathy, from what I understand, was started by an anesthesiologist years ago. And basically what they did it to simulate when they go to intubate a patient, how much room they actually have to get the intubation down there. We always do a Mellompathy. We want to see how much room is when we stick the tongue out, how much room we have back there, as well as we always do a pharyngeal score as well too, because we want to see how the posterior pharyngeal walls are, what's the uvula like, how long is the soft palate, all those things come into play.
Right. Especially like you said, when they're relaxed and laying on their back, gravity takes its toll, and especially when there's alcohol involved.
Yeah.
So what other risk factors is it that increases your risk for obstructive sleep apnea? Would you say that you tend to see other than obesity or alcohol?
Oh gosh. Cardiovascular disease. Most people who have cardiovascular. I mean, I'm a perfect example. Again, you don't mind me using myself.
No.
I went into AFib a few years ago. I had no idea I had sleep apnea, and I decided to be an adult about it. And I went and had a sleep study, spent the night in a sleep lab, and there I do. I have sleep apnea.
Wow.
And all sorts of cardiovascular disease plays a direct correlation between them, as well as your sleep apnea is going to exacerbate those things. And that's really what we're really concerned about. When you have a history of AFib and you have sleep apnea, you're just setting yourself up for the possibility, increasing likelihood of having a stroke.
Yeah.
And,
Right.
That's, to me, as I get older, that's the most frightening thing for me.
And we know how sleep apnea can increase hypertension, like the blood pressure. We know there's also a direct correlation with sleep apnea and low testosterone. And, which one comes first, right? So
Diabetes too, because when you have an apneic event, you get a vasoconstriction, you get cortisol release. It throws all the hormonal balances off. And so people who are propensities for diabetes, their sleep apnea is going to possibly exacerbate it as well too.
absolutely.
And we talked about obesity and sleep apnea, but people don't realize that even if you lose the weight, doesn't necessarily mean that the sleep apnea is going to go away.
Correct. We do see it. I have a dear friend of mine, and he's a physician in Clearwater, and he was morbidly obese, and he lost like about 145 pounds. And he used to use a CPAP, and his apnea pretty much resolved until he put about 65 of them back on. So yeah, you're right. It may lessen the severity of it, but you don't cure sleep apnea, you manage it, sort of like diabetes.
Yeah.
I like that description. It could be a chronic condition. It's just managing it.
It is exactly a chronic condition. It ain't going anyplace.
Well, and we know obstructive sleep apnea is the most common sleep-related breathing disorder. And people with obstructive sleep apnea repeatedly stop and start breathing while they're sleeping. And so this can definitely contribute to your daytime fatigue and somnolence. And I can't imagine, this is the fatigue that you have to drink tons of caffeine and you're still not feeling awake.
Yeah, we see that in many patients, and we see patients who many people aren't even aware they have sleep apnea, they have no symptoms at all. But the excessive daytime sleepiness really is a concern because people are out there driving.
Exactly.
People out there doing things using machinery, and they're putting themselves at risk or other people at risk from, possibly falling asleep at the wheel. We have many patients who have told us they have fallen asleep at the wheel. And one person I remember several years ago ran into a fountain at the entrance to his development because he's just snoozed out while driving, So,
it amazes me that how underdiagnosed sleep apnea is. So many people have it, and I think every truck driver should be tested for sleep apnea. Every airline pilot should be tested for sleep apnea.
I was just going to say that one too, yeah.
That one of the problems we have is with some people who they do the Epworth Sleepiness Scale, which is a very subjective report. And the insurance companies really want that, but it's a very subjective thing. So typically when we see people having these Epworth Sleepiness Scales filled out, patients think they don't have any of the symptoms.
Right.
And so there are better tools like the Berlin Sleepiness Scale. There's the Pittsburgh, I forgot the exact, but there's a Pittsburgh one too. You might be familiar with it. There are other subjective. The Stop Bang is another one.
That's my favorite one, but insurance companies don't accept that one.
No, they don't. And the Epworth is just, it's really a false pretense because we tend to, in our office, instead of letting the patient fill them out, we tend to ask the questions ourselves. So we pose the questions in a manner that we feel, hopefully we're going to get a much more honest answer. But the sleepiness is a real concern.
Yeah, and there's so many people who complain of fatigue, daytime fatigue. They should be talking to their primary care doctors or their doctors about being tested for sleep apnea.
No question about it. It is a highly prevalent disease in our country.
So, forgive me if I'm wrong, but there's a few different types of sleep apnea, right?
Yes, sir.
Could you explain?
There's basically two types of sleep apnea: obstructive sleep apnea. We talk about that, referring to it sort of like a cork in the bottle. The effort to breathe is still there. Think about shaking up a champagne bottle. You see the bubbles going in there. Take the cork out, air goes. Obstructive sleep apnea is some part of your neck, of your tongues, your airway is collapsing, your upper airway is collapsing, and for whatever period of time. Definition of an apneic event is at least 10 seconds. But we see people have apneic events 30, 40, 50 seconds. Oh, yeah. And so, so that's the primary type. That's an obstructive event. The other type of sleep apnea is called central sleep apnea. And central sleep apnea is totally different. Central sleep apnea is your brain says, stop breathing. It's
Yikes.
not. And so those people who have obstructive sleep apnea, they need to be using a CPAP because an obstructive sleep apnea with an oral appliance, the chances of getting a resolution with that is really, really complicated and slim. There are some events you may see what they call complex sleep apnea, which is a little bit central and a little bit of more obstructive. Some of those people will respond to an oral appliance, but when you have central sleep apnea, you really need to be using a CPAP because that's really the only way you're going to be able to manage it.
Well, how do you determine what type they have?
Yeah. Above my pay grade, really.
Okay.
So those, so there's two different types of sleep studies. The most in-depth sleep study is what we call a polysomnogram, and that's done in a laboratory, an overnight study where you have to sleep in a bed, and there's cameras on you, and you're all wired up, and it's. I didn't think it was bad, but most people don't like it. It's not the most pleasant thing. That's probably that is going to give you the most accurate information, the most in-depth information, because they're doing EEGs. They're able to see the different stages of your sleep. They're measuring. They have an EKG at the same time. They're measuring your pulse rate, your oxygen level. It's just more accurate. But what's become more prevalent, particularly since COVID, and also because the insurance companies don't want to spend the money for an in-lab study, has become home sleep study units. And there's various different home sleep study units. Some are much better than others. Probably, and I think you're familiar, the one that I think we like the most is called the WatchPad. Mm-hmm. And it's all done by an algorithm. A lot of the sleep physicians don't like it because there's no effort belt or nasal flow, but it's done comparison studies and it's incredibly accurate. There are a lot of sleep studies out there that are ordered by a lot of physicians that don't show position.
Right.
And I don't know why position is so important.
Yeah.
And we try to encourage the physicians when we talk with them, because as a dentist, Medicare, I can't touch a sleep study. And most insurance companies aren't going to pay for a sleep study done by a dentist. As a dentist, I can manage, I can treat your sleep apnea. I can't diagnose it, nor do I want that responsibility.
Just another restriction from insurance.
Yeah, well, that's, yeah, I guess that's insurance. Yeah, it is. Medicare is very specific about it, though. Medicare specifies that a dentist must do an oral appliance. Physicians can't do oral appliances because they're custom made. And as you said before, who knows the mouth better than a dentist,
Mm-hmm.
Exactly.
There are some ENTs out there who may do some appliances, but you can't put a claim into Medicare for that.
Now, some of the other at-home sleep studies, I know we've heard of some coming in that they also don't check to see if you're snoring either. They don't pick up audio. No. And I like to hear the audio, I don't hear it, but it's shown on a diagram and you can see if there's, movement, like you said, position. We know when you lay on your back, that's the most common position where people snore and they get the obstruction the most.
It's a very sore point of contention for me because once again, my role as a dentist is to manage them, get them to the point where we think they've reached maximum medical improvement. And at that point, I send them back to the physician. And because they referred them to me and ultimately they're responsible, I tell my patients, the physician's the captain of the ship, I'm the first mate. And I can't tell you how many physicians frustrate us. And I'm not trying to be critical of them because they may not know any better, but they do some of these studies. Blackstone, Snap are two of the companies that their studies are not up to standard that we really need to have in order to make sure that we are being effective. The efficacy, the whole point of that study is to document efficacy of what we're doing. or do we need to do more? And the watch pad is fantastic. Matter of fact, the watch pad now has, I don't know if you're familiar with the watch pad 1.
Yes.
Watch pad 1s are fantastic because you give it to them, they throw it away.
Exactly. That's the one we use in our office.
Yeah, it's the best.
It really is.
It is the best.
And the data is amazing.
A lot of information.
It does.
Well, now they show centrals now on that one. And now Itamar is the next generation, I believe, is going to start showing AFib. And so, yeah, they're making really good progress. And it's, as far as I'm concerned, there's no other one that I want my patients to use. But
same with us. That's the only one we use in our office.
Yeah, you get the most information from it there. It really is.
Yeah. And so when you diagnose sleep apnea, there's 3 different stages, right? Mild, moderate, and severe sleep apnea.
Yeah, I hate that term mild. I can't tell you how many times we have patients come in and say, yeah, well, Dr. Maria said it was only mild apnea, and it really undermines the significance of it. I wish that the American Academy of Sleep Medicine, where they're coming up with these classifications, didn't use that word, because it really, you think about it, mild could be, so when you get a sleep study score, we look for it, the acronym is called the Apnea-Hypopnea Index. You're looking for 2 different things in a sleep study for the most part. You're looking for apneic events, which is defined as where your airway is totally obstructed for at least 10 seconds. The other thing you're looking for is hypopneas, which is a partial obstruction of your airway. Think like a thumb over your hose and you're spraying your friends with water, and the level of your oxygen in your blood drops at least 4%. That's Medicare qualifications. They add up the apneas, the hypopneas divided by how much time you slept. Here's another thing about those other those home sleep study units, and where you get in wrong apnea-hypopnea index, because you turn it on and it starts to record. You turn it off and it stops. So you have this big sampling where really they only slept this much. So your AHI is probably higher on those patients.
Oh, that's an interesting point you make, because I always personally was thinking that when you go to a lab, people always complain when they go there. They're like, there's no way I'm sleeping because I go to bed at 10 and then they wake me up at 3 a.m. and say, you got to get out of here because we have to clean up the equipment.
It's more towards 5, but because they're doing EEGs, they know when you're sleeping.
And an EEG is more like the brain wave.
It is. That's exactly what it is. The brain waves. Yeah. Yeah.
So they can really see their sleep cycle with an accurate EEG.
The watch pad, and there's another one out there. It's called the Aries by Watermark. Those are the only 2 who really will show some degree of staging of sleep, which is really important for us. But like I said, it just shows so much more. But 0 to 5 is normal. 5 to 15 is mild. 15 to 30 is moderate. 30 and above is severe. And we get patients who come in with an AHI of 13 and a half. And but it's only just mild. Then what we try to sit them on is say, okay, well, let's look at it this way. If we just use the number 15, that means once every 4 minutes, your airway is obstructed.
Wow.
And could be for 20, 30, because we don't know how long those events are. Our sleep studies don't break them down nearly as much as an in-lab study can do a little bit more. So I wish they'd come up with another term other than mild, because it downplays the significance of the disease all the time.
Well, which goes back to us saying how underdiagnosed sleep apnea is.
Yeah. And also shows how medicine today has become so numbers based, right? With diabetes, it's the A1C. That's all. Your blood sugar could have a range between 30 and 400, and your A1C could not even reflect that.
I'm naive to glucose. Aren't glucose levels are monitored nearly as much as the A1C today?
Well, now people are using the CGMs, that's more accurate. That's the continuous glucose monitor. So that really shows you better representation. Whereas the A1C is a 3-month average, and it's the same thing with the AHI. It's a night-long average.
Yeah, it's just, they're just not, they're underdiagnosing or downplaying the significance of the disease. And it makes all of our jobs more challenging when they come from the sleep physician and they go, it's just mild. Well, yeah.
And we still, with everything we do, we go by symptoms more than anything else. If someone has a classification of mild sleep apnea, but yet they're telling us they're falling asleep in their car at a red light, it needs to be treated. You need to do something.
Yeah, exactly. And that's really true. But again, it tends to be downplayed because of that terminology. It's very frustrating, because then we have to And we do a lot of education. We find a lot of patients come into us and I say, so did your doctor go over your sleep study with you? Well, not really. He just told me I had mild, moderate, severe. So we kind of go through it and educate them to what exactly is happening on their sleep study and show them what their apnea really is, truly is.
Right.
And the impact it's having on their overall body.
So once someone's diagnosed with sleep apnea, then we do a treatment of sleep apnea. And there's several different forms of treatment. We can start with CPAP machine, and that stands for continuous positive airway pressure. And basically that's exactly what it is. It's a machine that blows air into your nose or into your mouth and with enough force to hold the back of your throat open.
Correct. It's, I tell patients that pressurized air sort of like opens up your airway, sort of like a balloon, putting pressure on the airway, preventing it from collapsing. And I'm a big CPAP proponent. We know the most I hate the gold standard terminology. I think what the appropriate one is for CPAP is it's the most predictable means to manage your sleep apnea. The caveat is if you can use it, and we know that greater than 50% of the people can't, won't, or don't. I'm a perfect example. I've been using my oral appliance since I got diagnosed, but I had some friends of mine convince me to try CPAP recently. And I tried it for 3 nights and I felt like I was suffocating. And I just couldn't use it. It's not an easy device to use, but those who can should. Those who can't.
We have some patients who insist they can't, and they end up loving their machine, and they won't even take a nap without their machine.
Amen to them.
But it's more uncomfortable the higher pressure you need. So the worse your sleep apnea is, the more pressure that's being blown in there, and especially on exhalation, because it's still blowing the same pressure in whether you're inhaling or exhaling.
Right. And that's the challenge with a CPAP as opposed to a BiPAP, which will lower the pressure when you exhale. But we have many patients who will use their oral appliance and their CPAP at the same time because they're able to lower their pressure when they do that.
I was going to ask that question because I feel like that would make things more comfortable.
Well, it makes it more tolerable for those people who can't tolerate the hyper. When you're getting 14, 15, 16 centimeters of water blowing up your nose, it's a very uncomfortable feeling. So with the oral appliance, bringing the lower jaw forward opens up the airway and allows them to reduce the pressure.
Well, and there's also different fittings, correct? You can have it just under.
There's different masks.
Right, different masks, right. Yeah. So you can have where they cover the nose and the mouth.
Right.
Just the mouth.
Right.
And then just the nose.
They've got, I tried the nasal pillows. I wasn't comfortable with that. They have another device where you use your nose, but it kind of comes up underneath your nose and it still covers your mouth. Because if you open your mouth with a CPAP, the air is going to go down your nose, out your mouth, not down your throat. That's why some people may use chin straps or use lip tape.
Interesting.
And that will help to promote lip closure. If you can't put lip closure with nasal pillows,
it defeats the purpose.
It defeats the purpose. Exactly.
I've seen those chin straps. I didn't realize that's what it was for.
Yeah.
Gotcha.
And people use them with oral appliances too, because our goal is to try and promote nasal breathing. There's so many benefits for them to be nasal breathing. That's why we do a Cottle maneuver test, check and evaluate the nasal valve. We diagnose, we use nasal dilators, which nasal dilators actually go internally or inside the nose, prop open the nasal valve, and they're much more comfortable. They're less expensive because breathe right strips are expensive. It's one-time use and you pull off skin. These nasal dilators, as a matter of fact, I wear them every time I exercise because it facilitates my brain to say breathe through my nose instead of my mouth. We are much more effective at managing people's apnea and snoring if we can get them to breathe through their nose and seal their lips. Much more effective.
Interesting. And then we've talked about the oral appliance. Is there any other detail that you'd like to give?
What's the process of having an oral appliance made?
Okay, thank you. It's much different today than it was when we made one for you. We don't do traditional dental impressions anymore, which really scares a lot of people. We don't shove all that goop in your mouth and make you gag. Thank God for technology. We scan everybody now. We have a camera that does a 3D dimensional scan of the patient's mouth, and then we're able to send that to the manufacturer. We do certain things. Part of our process is we are going to do an examination, and we're going to take a look around your mouth we want to make sure you have enough teeth to hang the hat onto. Okay. We tell people, we can do people who have dentures as long as they have lower teeth. But we will do an exam and I'll take a look, as we talked about, MY-APNEA, pharyngeal grading. And we just want to make sure everything structurally looks right. We want to evaluate the teeth to see how high they are. Is there curves to them? Are they missing any teeth? And that's how I kind of make a decision about what type of an appliance that I'm going to prescribe for them. We scan their teeth, and the modern miracle of the internet, we hit a button and boom, it's right off to the manufacturer and they can start making them. Typically, it takes about 3 to 4 weeks to get the appliance back from the manufacturer. They come in, we deliver to them, we fit it, we make sure that they're comfortable with it, give them instructions how to use it. We make an appointment for them, typically in 2 to 3 weeks, to come back and evaluate their initial response to it. And every appliance has the ability to bring the lower jaw further forward over time based upon evaluation. When I do my examination, I will make my best educated guess at where I position the lower jaw in reference to the upper jaw in the appliance that I think it's going to best open the airway. But in all honesty, until we make it for them, we don't know. And so every appliance has the ability to bring the lower jaw further forward based upon evaluation. Now, it's all subjective at that point. But when we get to the point where the patients feel like we've done as best as we can, that's when we send them back to you for another sleep study to document objectively the efficacy of the device. And there's lots of different appliances out there. Medicare requires we do what we call a fixed mechanical hinge. It's a fine appliance. I wear that type of an appliance, but there are dozens and dozens of appliances out there. Compared to the ones you buy over the counter.
Right.
They can work, but they're not custom. Most of those have what we call a monoblock, which means it's fixed at one position. You determine what position, and I'm going to be right there. Oof. And you can't adjust it, like I said, with a custom-made appliance. They're not necessarily smooth. They're bulky. And obviously a custom-made appliance to an individual's mouth is going to be a much more comfortable thing. Some of the appliances have flexible liners in them, so they're a lot more comfortable, and we don't have to use any metal. So there's lots of different appliances out there.
What happens if someone has dental work done after their appliance is made?
That's a great question. We really go to extremes on that. We've gotten to the point where we have a card that we give our patients that is actually for them to give their dentist. And so if somebody has a filling or a cleaning, there's no impact. But if they have to have a new cap or a crown done, we ask our patients to have the dentist contact us before they start. That's what the card is for. And we coordinate together. And if it's just a crown, one single crown, 2 crowns, we're able to work together to coordinate so we don't violate the integrity of the appliance. We have patients who get a lot of work done after their appliance, and there's nothing we could do about that. But if it's just 1 or 2 crowns here or there, it shouldn't violate the integrity of the device if we work together.
How long does a device last?
I have patients who have devices over 10 years. Medicare, we always go by what Medicare rules are.
Right.
Medicare will replace an appliance once every 5 years. And when we tend to, what our regimen is when our patients have gotten, we think the appliance is effective as possible, and they've had a study and we know where it's at. We see them 3 months after that, 6 months after that, and then we see them annually to make sure the appliance is intact and they're still wearing them. When they get to the 4-year point, we will let them know that they're eligible for another appliance if they want. Technology changes. Here's a perfect example why you need another appliance. This happened to me about 4 months ago. I got up every Wednesday. I get up to go to my Melbourne office at 5 in the morning. I get out, take my appliance on. I don't do this. Put it on my nightstand. Guess who got my appliance?
Dog. Yep.
So that's another reason why I encourage patients when they're eligible to get another appliance. We've had patients lose them in their luggage. They leave them in their luggage. The airline loses them. They leave them in hotels. You think of it always. So it never hurts to have an extra appliance at that point, whether or not the other appliance is still in good shape or not. And again, like I said, technology changes all the time. Most of our appliances now are either printed or milled. So they're much more precision than they ever have been before.
Wow.
Yeah.
So while we're talking about treatment for sleep apnea, we get a lot of questions about Inspire, which is one of the newer technologies.
Right.
Inspire is a hypoglossal nerve stimulation therapy. It's kind of like a pacemaker for the back of the tongue.
Yeah,
right?
yeah, kind of.
What do you think of Inspire?
I think there's a place for everything. It is an invasive surgical procedure. It's very expensive. They embed a battery pack into your chest. They take two wires. One wire they take and attach to one of your intercostal muscles so it can evaluate your breathing. And then they take another wire and they bring it all the way up to the hypoglossal nerve through the base of your neck and they clip it on there. Nighttime, you take a little remote control. You've probably seen a television, put it over it, and it stimulates your tongue to come forward. It does have the ability to calibrate. It can be effective like anything. One of the things that really challenges me about it is that Medicare calls when an appliance is effective or CPAP is effective, we have to reduce their AHI at least in half and get it below 10. Inspire, get it below 20. So you can have an AHI of 19, still have moderate sleep apnea, and they consider it to be successful, which I think is a joke.
No kidding.
It is. But there's a place for everything. And if you can't use a CPAP and you can't use an oral appliance, something's better than nothing. So there is a place for it. It's very expensive. Battery needs to be replaced every 5 to 7 years for another surgical procedure. Pros and cons for everything. But it certainly is viable. But like I said, it's invasive surgery. So
Doesn't sound like a first-line therapy.
no, definitely. Although they promote it that way, I
Right.
don't believe it's first-line therapy. No, I'd much rather use a CPAP or an oral appliance.
And there's some contraindications. I know they say it's not very good for people who have a BMI greater than 33.
Yeah, it's possible. I mean, but again, BMI isn't all I would really go more of the fat content test.
We do the body fat.
The body fat, yeah.
That's much more. BMI is just I don't know.
We agree.
You are preaching to the choir. That's like
said, they consider me to be obese, and it's a joke. So, but there is a place for Inspire, but I think it's limited at this point.
So we've talked a lot about sleep apnea, and we do encourage people listening. If you're having tiredness, daytime fatigue, talk to someone about getting checked for sleep apnea. It's not a difficult test anymore. The home sleep studies are super easy, and they're comfortable.
The WatchPad is so easy now.
And people always were terrified of going to sleep in a lab and sleeping in a strange bed. And not only that, but the treatments now are great. Our patients much prefer the oral appliance over any of the other treatment modalities.
It's less invasive. Maintenance is another big issue for a CPAP. I mean, that's maintenance on those things. You got to be washing out the tubes constantly, cleaning the masks, emptying the reservoir.
It's a high risk for infection.
High risk for upper respiratory infections. Oral appliance, when they get your oral appliance, we give you a denture brush, which is basically a very coarse toothbrush. We tell you to take some plain old antibacterial soap in the morning,
scrub
it off, put it away, you're done. It's that easy. So maintenance-wise, it's a much easier thing. It's not as invasive, but it's not for everybody, obviously. Like I said, I think CPAP is the most predictable way. And if you have severe apnea, I always feel it's important to give that a try if you can. If you can't, we treat severe apnea all the time. You asked about cases. We've seen people who have AHIs in the high 90s. Oh,
wow.
We get them down into the teens. I wrote a paper back in 2017. We studied 300, it's anecdotal because and this is back then, nobody was doing home sleep studies. We studied 305 patients who all had, before sleep studies in lab, polysomnograms, and after with their appliance and a polysomnogram. The average AHI for those patients, moderate to severe, was 39. At the end of averaging out was 11.
That's phenomenal.
So it does work for severe. It's a misnomer. We hear from a lot of physicians and sleep techs, it only works for mild. Well, no, it doesn't. And actually, the American Academy of Sleep Medicine, they say that first-line therapy for mild to moderate is an oral appliance. Severe, they like to do a CPAP trial. And if you can't use a CPAP, well, darn, something's better than nothing.
True.
Absolutely.
And that's the mentality we try to get across, that when we talk with patients, because sometimes, look, you have a patient who's hypertensive. If that high blood pressure medication doesn't work, you're not going to throw your arms out and say, well, I guess you're going to stop that. You try a different medication. And far too often the paradigm has been for so long, CPAP, 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 CPAP. And so I love the fact that we're doing this to bring more of the word out there for oral appliances, because it is a tremendously effective way. I know personally, my AHI is a little under 24. With my oral appliance, I got it down to 6.
Oh, wow.
So it works. It works, yeah.
Now, I know we talk about Medicare covering this. Does commercial insurance cover this? And is it just, do they cover part of it or all of it? Or is all depends?
Yeah, you guys know you have enough with insurance. Every policy is differently. It's always going to depend upon what their deductible is. And oral appliances are considered durable medical equipment. So they're in the same line as which is oxygen, wheelchair, crutches. And everybody, unbeknownst to and I had no idea until I started this, everybody in their commercial insurance has a DME percentage. And most people aren't aware of this. So depending upon what your deductible is, depending on what the allowable is, and depending on what your DME percentage is, there usually is some cost involved. It depends on everybody's different.
Okay, thank you.
Yeah.
All right. I think this was so informative. I'd love for you to tell our listeners how they can find you.
My website is, my name of my office is, we call it Florida Dental Sleep Disorders. So it's FLDSD.com. Obviously, our phone number, 561-353-5252. We have offices in Boca Raton, Vero Beach, and Melbourne.
Wow.
Yeah, we're busy. We try. I've had my car for a little over 3 years. I just went over 90,000 miles.
Wow.
I drive a lot.
It sounds like it.
I drive way too much.
Well, thank you for being there for our patients. Thank you for coming on to our podcast and for our audience.
It was a pleasure. It really was. I enjoyed it. It was fun, and I hope we make a difference.
Yes.
Thank you.
Thanks.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.